Thank you, Dr. Abdul Wahab, for your kind words. And I'd like to thank the organizers and TAKEDA for the invitation. So I will be talking about advanced stage Hodgkin's lymphoma, and I'll emphasize particular things about the Echelon 1 study, in particular the 6-year overall survival data and the updates on that, and what the future holds. So these are my disclosures. This is a disclaimer from TAKEDA. So this is one of my favorite slides because it's a package of the history of Hodgkin's lymphoma in one slide over a period of since 1935 to 2000. And there was actually a very nice publication by Vincent de Vita back in 2003. Vincent de Vita, for those who are pretty aged like me, you probably know that he was a very powerful figure at the NIH in the US back in the 60s and 70s. When Richard Nixon, the president then at the US, declared the war on cancer, he was actually one of the powerful figures that spread the money that Nixon gave at that time to the academic centers. So what does this slide show us? It shows us the rates of deaths from Hodgkin's lymphoma from 1935 until 2000. And what you can see is that with the introduction of radiotherapy, with the crude techniques back in the 50s with Covalt, you can actually see that you're starting to see a plateau at the curve, which suggests that probably you're starting to cure some patients with early stage Hodgkin's lymphoma. This became more evident with the linear accelerator back in the 60s. And after that, with the introduction of combined chemotherapy, with the combination of MOP, there was a decline in the deaths, as you can see, and a more rapid decline when combined modality, which is the combination of chemo and radiotherapy, started to be used in these patients, in particular those with advanced stage disease. Now, the breakthrough came in 1975 when the Italian group and Bonadonna and his group devised the ABVD combination chemotherapy, which was clearly less toxic than MOP and with probably more efficacy. And since then, ABVD remains the cornerstone of treatment of Hodgkin's lymphoma. So in advanced stage disease, 6 cycles of ABVD generate a 5-year progression-free survival of around 70%, as you can see from this study from Stanford, and an overall survival of at 5 years of 85%. So clearly, there is a 30% of patients who actually fail ABVD, and we need efforts to improve the outcome of these patients. The German Hodgkin's lymphoma study group devised the escalated BCOP combination, a quite toxic regimen, which undoubtedly, if you look at the randomized phase 3 trials that are in the table here, showed a statistically significant difference in improvement of progression-free survival in the escalated BCOP arm. But as you can see on the right in the gray, this did not translate into an improvement of overall survival compared to ABVD. And the reason why is because clearly there were more toxic deaths and toxicity related to escalated BCOP, but more importantly, as you can see here with longer follow-up, first from the HD 2000 study, you can see regarding survival rates, no difference, 85% ABVD, 84% in BCOP, but as you can see, the rates of secondary malignancies at 10 years, only 0.9% with ABVD and 6.6% with escalated BCOP. And at the right, you look at data originating from the German Hodgkin's lymphoma study group with 10 years follow-up. If you actually received 8 cycles of BCOP, you had a 10% chance of developing cancer at 10 years. So what else have we seen in the past decades? We've seen an improvement in the imaging of patients with Hodgkin's lymphoma in particular, well, in lymphomas in general, but in Hodgkin's lymphoma in particular, with the introduction of functional imaging with FDG PET scans. And this has been widely adopted, in particular with the reproducible scoring system, the DeVille score, the 5-point DeVille scoring system, in which patients who have a DeVille score of 1, 2, or 3 are considered in complete metabolic remission, while those who have 4 or 5 are either non-metabolic responders, partial metabolic responders, or patients who have progressed, depending on what the baseline PET-CT scan showed and what, with evolution, the subsequent scans demonstrated. And it's been clearly shown that the end of treatment PET scan has a prognostic and predictive value in terms of prognosis. And here you can see that it has a high negative predictive value. And just to remind you about statistics, how the negative predictive value is the truly negative divided by the truly negative and false negative. So it's around 86% in this study, which is pretty good. But if you look at the positive predictive value, it's intermediate, because as you can see, there's a significant rate of false positive, which reaches 46% in this study. So patients who are positive but still remain disease-free with long-term follow-up. What about interim PET scan? It's been shown also that interim PET scan has a highly prognostic and predictive value. So if you have a negative interim PET scan, you're probably going to do well after 6 cycles, as shown in multiple studies, as you can see here in the figures. So this led to the concept of PET-adapted approach strategies, okay, based on the results of interim studies. So this concept, first of all, you can have a variety of strategies we'll go very quickly through. So you can start with ABVD, and for those who are PET positive, you can escalate to BCOP. Now, if we look at the PET negative patients after ABVD 2 cycles, that's patients who are DeVille 1 to 3, I have 3 studies here. The US intragroup study, which included exclusively patients stage 3 and 4, and has a median follow-up of 5.9 years. And as you can see, the 5-year progression-free survival was 76%. The Rathel study, with an update presented at ASH last year, as you can see, with a median follow-up of 7.2 years. I must emphasize here that the Rathel study included also patients with stage 2. Actually, 40% of these patients were actually stage 2. And I'll remind you, those were the patients who were ABVD, who were PET negative after 2 cycles, or bleomycin was omitted. And again, here you can see the 7-year progression-free survival is around 79%. And we have the Italian study, which has a median follow-up of 3.5 years and also included stage 2, around 35% of patients. 3-year progression-free survival, limited long-term follow-up in this study, 87%. So what's the message from these 3 studies? I mean, number one, ABVD clearly is not effective even in PET-negative patients, because as you can see from the intergroup study, 25% of patients fail. The second thing is that PET negativity is not that reliable, because 25% of patients who are PET negative actually relapsed. What about PET positive? So these are patients who are PET positive after 2 cycles of ABVD, and they progress to receive escalated BCOP. So if you go to the intergroup trial, we can see that the 5-year progression-free survival is around 66%. The Rathel study, 7 years progression-free survival, 66%, and the 3-year progression-free survival for the the Italian study, around 60%. What's the message from here? Clearly, the interim positive PET scan has a negative predictive value, because the results are not as good as the ones we saw in the PET negative patients. And the other thing is, as you can see from the US intergroup study, the risk of secondary cancers is quite elevated in the patients who were treated with escalated BCOP. Another strategy is patients who are PET positive to go direct to salvage chemotherapy and autograft these patients. This is an Italian study, and you can see here the 2-year progression-free survival for the PET-negative patients, i.e. those who continued on ABVD, was 75%, and the 2-year progression-free survival for the for the PET negative was 81%, for the PET positive, i.e. those who went for salvage and auto, 75%. But if you look at the overall survival curve, it's pretty good for both both categories of patients. A third strategy is starting with escalated BCOP, and if you are PET negative, to de-escalate to ABVD, and if you're PET positive, to continue it with escalated BCOP. And as you can see here, this is from a French study that also included patients with stage 2B disease with a median follow-up of 5.5 years. There was no difference in the progression-free survival in the standard arm and the experimental arm, and also overall survival superimposing curves. So what's the conclusion? Well, I mean, clearly in the PET positive patients, you can see that the results are inferior compared to those that are PET negative at the end of treatment, even if you modify the treatment. So what about patients who have an interim PET scan and who have been treated with ABVD? I mean, this we find it quite often in clinical practice. What do you do with these patients? You have to decide, are you going to switch them to another treatment? Are you going to salvage them? Are you going to... So the Sloan Memorial Kettering looked at patients from their database in which they were PET positive after 2 cycles of ABVD, but they decided to continue with ABVD. And they included a number of 227 patients who fulfilled the Rathel study criteria. So they were from stage 2 to 4, and who were they considered interim, PET negative as DeVille 1, 2, or 3. Now, 31 patients, so it's 14% of patients had an interim PET scan was positive, and of those patients, 23 continued on ABVD, as you can see, which are the yellow line, as you can see here in the survival curves, while 8 patients received escalated BCOP, that's the gray curve. And as you can see, the 3-year progression-free survival, even for those who were PET positive, was 64%, which is pretty good, considering that they under certain other conditions, they could have been switched to another treatment. And if we look at the patients who were treated with escalated BCOP, you can see that the progression-free survival was only 56%. Again, for the PET-positive patients who have a 64% progression-free survival rate, this was pretty good. And if you look at the overall survival curve on the right, these 3 categories of patients that superimpose, suggesting that even if you don't modify your treatment and these patients actually do progress, which will be around 40% of patients based on the curve, still you can salvage these patients and have excellent overall survival rates. So just the synopsis of what we've said until now is that escalating therapy has not improved overall survival compared to ABVD, and PET-adapted treatment, as I've showed you, is not perfect, since we have a significant number of patients who are false PET negative or false PET positive. So what about in the era of novel agents? So we know very well from the Echelon 1 study that the addition of brentuximab to the combination of AVD and omitting bleomycin from this combination, I'll just remind you that brentuximab is an antibody-drug conjugate. It targets CD30, and this combination has been shown in multiple publications of the Echelon 1 study that it improves the efficacy and the progression-free survival of these patients. And I'm going to present you some data from the 6-year follow-up of this study, which has some significant overall survival data. And I'll also present some data on the efficacy on the safety of this study. So the background is that to date there hasn't been any combination to demonstrate an overall survival advantage over ABVD in a direct comparison, as I showed you previously in all the previous data I demonstrated in patients with advanced stage Hodgkin's lymphoma. Now, analysis from the Echelon 1 study with 3, 4, and 5 years follow-up demonstrate a durable progression-free survival in the AVD arm, which is superior to that of ABVD. And apart from that, this also applies also for key patient subgroups, irrespective of interim PET scan, a disease stage, and a baseline IPI. And updated efficacy and safety results of the Echelon-1 study have been reported after a median of 5 years, with safety data focusing on peripheral neuropathy, secondary malignancies, and fertility. Now, if you look at so this is the study design, just to remind you what the Echelon-1 study was. And this is a clear one-to-one randomization between AAVD and ABVD, 6 cycles. I'll just remind you that there was an interim PET scan done after 2 cycles, but treatment was not modified based on the PET2 scan. So the patients continued and completed their treatment until the end of treatment. The primary endpoint was progression-free survival, and key secondary endpoints included overall survival, and there was a long-term follow-up assessment of exploratory analysis looking at the PET2 positive and PET2 negative patients and comparing both arms. The progression-free survival, looking at safety and secondary malignancies and outcome of pregnancies and peripheral neuropathy. Now, here is the updated 6-year progression-free survival, and as you can see, there's a superior progression-free survival in the AAVD arm, with a reduced risk of progression of 32% when compared to that of ABVD. And more interestingly, if we look at the overall survival, for the first time, there's a study in which a combination which has a comparative arm that includes ABVD shows an improved overall survival. And as you can see here, there was a difference in the overall survival with a hazard ratio of 0.59 and a 41% reduced risk of death in the AAVD arm compared to ABVD. Clearly, the number of deaths, as you can see, were 39 in the AAVD arm compared to 64 in the ABVD arm. Now, this is a forest plot that shows that there was an overall survival benefit in the brentuximab vedotin arm compared to that of the ABVD, and this was consistent across key specified subgroups, although one should caution that when you do forest plots, you need a significant number of patients to analyze the data, and so it can be tricky sometimes. But anyway, here there was a clear, as you can see, overall survival benefit. If you look at the on the left, it favors AAVD. On the right, it favors ABVD, and you can see clearly that the overall survival benefit was superior in pre-specified subgroups, which included the patient's age above or below 60, geographic regions, stage 3, 4. And also, if we look at the exploratory analysis, there was also an overall survival benefit for both PET-negative patients and PET-positive patients in the brentuximab vedotin arm. Now, just recently, there was a publication focusing on the adolescents and young adults. This includes patients between the age of 18 and to 39. And as you can see here, because it includes a significant number of patients, as you can see, it's 58% of the intention to treat population. And you can see clearly here that there's a statistically significant improvement in the progression-free survival in the brentuximab vedotin arm. And again, overall survival rates in favor of the brentuximab vedotin arm, hazard ratio is 0.39 with a clearly superior overall survival. And if we look at the outcome based on the interim PET scan, you can see on the top for patients who were PET2 negative, again, superior outcome in the brentuximab arm compared to the ABVD arm. And even in the PET-positive patients, again, a superior progression-free survival in the AAVD arm. Now, what about deaths? There were fewer deaths in the brentuximab vedotin arm Specifically, if we look at Hodgkin's lymphoma or complications on the right hand, you can see that there were 32 in the AAVD arm and 45 in the ABVD arm. If we look at the deaths from secondary malignancies, strikingly there were 11 deaths in the ABVD arm and only 1 in the AAVD arm. And clearly, if we look at disease progression-related deaths, there were only 19 in the AAVD arm, while 28 in the ABVD arm. On the left-hand side, we can see the secondary malignancies. And clearly, there was no difference in the rates of solid tumors. As you can see, 14 in both arms. But if we look at hematologic malignancies, there were 9 hematologic malignancies in the AAVD arm compared to 17, almost double, in the ABVD arm. And interestingly, there's a hypothesis that maybe, excuse me, the addition of rituximab vedotin could affect and deplete these progenitor lymphoid cells, which could be associated with recurrence of the disease. So, but it was very interesting because when I was preparing the slides, I bumped into this publication, which I found very interesting. I said I would add it. And it actually it looked at the recurrences of Hodgkin's lymphoma in patients. And what they did is they took biopsies from the primary diagnosis and from the recurrence, and they did next generation based clonality tests for the immunoglobulin gene, for the T-cell receptor. They also did targeted mutational analysis. They also did extensive, as you can see, histomorphologic review. And what was the conclusion from that? First of all, they found that 70% of relapses were associated with the original clone, while 30% were not associated. So 30% of these lymphomas were irrelevant to the previous diagnosis of Hodgkin's lymphoma. And also, interestingly, they did T-cell clonality tests, and they found that 10% of these patients had TCR gene rearrangements, and half of these cases, excuse me, were actually T-cell lymphomas that mimicked Hodgkin's lymphoma. So you can see here on the right hand 2 examples. One is a case where the original clone had multiple targeted mutations, as you can see in the yellow and the green. It had accumulated a TET2 mutation, which didn't pre-exist, and there was also a difference in the IGH mutational sequencing between these 2 diseases, so clearly unrelated. And on the lower hand, another case for which there was a progenitor B-cell, lymphoid progenitor cell, which had a mutation of the beta-2 microglobulin gene, which was present in both cases of recurrence, but they differed in terms of the sequencing of the immunoglobulin, the heavy immunoglobulin gene. So clearly, there's a considerable subset of Hodgkin's lymphoma recurrences which are clonally unrelated and associated with a second primary lymphoma. And also, it's interesting that if you combine T-cell clonality, you can identify T-cell lymphomas which actually mimic Hodgkin's lymphoma. What about peripheral neuropathy? Clearly here, this slide just demonstrates that at 2 years, the rate of peripheral neuropathy in the BV-ABVD arm was 67% compared to 43% in the ABVD arm. But at 6 years, you had a dramatic drop in the rates of peripheral neuropathy, only 19% compared to 67, and interestingly, grade 3 and 4 from 11% at 2 years had dropped to 2.5% in the BV-ABVD arm. And again, if you look at the rate of resolution of the peripheral neuropathy over the years, you can clearly see that there was a significant resolution or improvement of the peripheral neuropathy in the patients in the BV-AVD arm over time. What about pregnancy data? I mean, I just want to clearly say here that there was no issues relating to pregnancy. Females and partners of male patients were very productive, and there was no issues with fertility compared to what we had in the past. Almost finished. So the implications of the Echelon-1 study. So this overall survival is an important benchmark because it's the first study to actually demonstrate an overall survival advantage of a combination compared to ABVD. Very quickly, we have two new treatment studies that were quite important, presented recently. One is the HD21 study, in which BCOP was compared to the BRCAD combination. I'll just remind you that BRCAD is a modification of the escalated BCOP, which was introduced by the Germans. And what they did is they eliminated bleomycin and vincristine. They switched from procarbazine to dacarbazine, and they reduced the steroids from 14 days to only 4 days of dexamethasone in this combination. And as you can see here, with a median follow-up of 40 months, very, very impressive results from this study. BCOP compared to BRCAD, 92.3%, 94.9% progression-free survival, very impressive results. Actually, the fertility data has not been presented yet by the Germans, but they say that the fertility data is pretty good. And we also have the randomized phase 3 trial comparing Nivo-AVD with brentuximab vedotin AVD that was presented recently at ASCO and at the ICML meeting in Lugano. This showed a superior progression-free survival compared to brentuximab vedotin AVD, but I must caution you that this is only a 12-month follow-up results. There hasn't been any publication yet. It also includes 25% pediatric patients, which would make subgroup analysis quite difficult. But we need to see more mature data and a publication to come to any firm conclusions regarding this study. So I think I don't have time, right? So I'll just close here. Sorry about that. Just to summarize, AAVD is the first regimen to show an improvement in overall survival compared to ABVD. Clearly, the overall survival favored AAVD compared to ABVD, with a corresponding 41% reduction in the risk of death. And I showed you that the safety profile was pretty manageable in the AAVD arm. There were fewer secondary malignancies and significantly fewer deaths from secondary malignancies in the study. And I didn't have time to show you, but in the era of the novel agents, the predictive power of PET-CT is changing, so you have to be very cautious how we interpret. And as you can see, the last studies I showed you, even the Echelon, the Alliance study with nivolumab, and the HD21, they don't take into account the interim PET-CT when in these studies when the patients were treated. So we need novel biomarkers to improve our rates of detecting patients who will fail treatment. So with that, I would like to thank you for your attention.
Thank you, John.